So it's the last talk, so I'm just going to try and be very concise and quick. So what I'm presenting today is one of our study and try to present the preliminary findings. And we're trying to answer the question of, does development of de novo donor-specific antibodies accelerate the progression of kidney allograft failure in children? So just an overview of what we're going to go through today is we'll try to explore what do we know so far about the topic, about the donor-specific antibodies and graft failure. We'll try to explore evidence from the adult data and go through some of the pediatric literature. And then we'll present the study findings and results, and then questions if time allows. So what do we know so far about it? We know for a fact that donor-specific antibodies have become an established biomarker in predicting antibody-mediated rejection. We also know that antibody-mediated rejection is a major cause of graft loss in kidney transplant, and we know it's really important to address the causes of kidney transplant, accelerated aging, and it's an important challenge, aiming for the outcome of improving long-term transplants. So regarding adult data, this is a data from France, published in 2017, where they have a large adult population of over 2,000 patients. They were enrolled. The main outcome that they've studied, and they've put it as the outcome for graft failure, is interstitial fibrosis and tubular atrophy. So they've studied patients who they've recorded DSAs, positive patients, and they recorded as well biopsy-proven IFTA, which is interstitial fibrosis and tubular atrophy. What they found that circulating DSAs positive are major determinants of premature and accelerate allograft fibrosis, acting independently of any other risk factors in that group. There are another data from the US, which was published 2 years later, 2019, where they've enrolled 294 adult population, and they followed them across for 4 years. The aim of this study was to understand the timing of development of DSAs and the role of medications, immunosuppressant and adherence. What they found that the combination of T-cell mediated rejection plus DSA positive led to an almost threefold increase in graft loss compared to either DSA's presence by itself and T-cell mediated rejection by itself. They've also found that patients who develop both DSAs positive and T-cell mediated rejection proven in their biopsies have 75% of these patients have impending graft loss by 4 years follow-up. So we do have these big studies from the adult population. Why do we need more studies in pediatric population? So we know for the fact the accumulation evidence in adult literature for the association between DSAs and poor renal allograft outcome. Pediatric data are limited. There are few published studies in this matter from the pediatric population, and they show different evidence. So some of them, they showed that there is no significant outcome from the presence of DSAs in the long follow-up. And one of the earliest published data from 2012 showed that there is a significant effect from the presence of DSAs in 10 years follow-up in pediatric population. Why is that? Possibly because of B-cell subpopulation in children mature in a different way, and it might matures more as the child grows and get older. This is one of the studies from the UK that was published in 2014. They followed up 215 patients between 2006 and 2012. They followed them with DSAs monitoring at 1 month, 3 months, 6 months, 1 year, and then yearly after their transplant. What they found that DSAs were not an independent risk factor unless patient developed microvascular injury proven in their biopsy. They've also found that the magnitude of effect of GFR is proportional to the MFI, which is the DSA intensity level, and mainly in class 2 DSAs. And they also found that in short term, the outcome of patients who DSAs resolved at some point after they developed the DSAs is more or less comparable to the patient who did not have DSAs at all. This is another study from the US where it was published in 2019. They have enrolled 103 patients, less than 18 years, and they followed them up between 2007 and 2013. They've done a DSA screening every 3 months for 2 years, and then additional DSAs monitoring if clinically indicated. So what they found that the screening detected de novo DSAs was not associated with decline in GFR or graft loss, and that tells the effect of the presence of DSAs in patients who have a stable kidney function. What they also found that de novo DSAs that were first detected on 4-cause testing was associated with 2.8 times increased risk of decline in the graft function. So coming to our study, these are preliminary results. So there is still work, ongoing work and data collection at the time being. But I'm just going to go through the results from what we got so far. So the aim of our study was to understand the development of allograft failure in children who developed de novo DSAs. What we've done that it's a retrospective observational review at a single tertiary hospital, following up patients in the last 10 years. We've included patients who had a transplanted kidney and they're less than 18 years, and we've extracted data from the electronic patient records. We have analyzed the demographics, donor and recipient characteristics, rejection episodes, DSA surveillance, progression of EGFR and immunosuppressant changes. We had a total of 117 patients. We've excluded around 25 patients just because one of the inclusion criteria in the study that we want them having minimum of 1 year follow-up. The mean age at transplant was 11.5 years with a median age of 6. The mean follow-up time was 4.3 years with a median follow-up time of 7 years. This is just to represent the underlying etiology for the population studied, and as we can see, the majority are CACUTs, and that represent what we know as the most common causes of kidney diseases in pediatric patients. So this table, we try to understand the characteristic of both groups who developed DSAs positive and no DSAs during their follow-ups. We had 33 patients in the DSAs positive and 59 patients in the DSA negative. And interestingly, the only statistical significance were around the patient who did have living kidney donors, and preemptive transplant, and the majority or the higher number did not develop DSAs during their follow-up. And just to understand the DSA positive group, we've divided them into 3 groups in terms of biopsy findings. So the first group were patients who had proven rejection in their biopsy, and then the second group who did not have any rejection in their biopsy, and the third group who did not have biopsies during their follow-up. We found that there was no statistical significance between the 3 groups in terms of timing of first detection of DSAs, peak of MFIs, and the decline in their eGFR, and that was calculated as mean delta eGFR across the years of follow-up. So this is just to see the difference in the biopsy-proven rejection episodes in both groups, DSAs positive and DSAs negative, and that showed statistical significance difference between both groups in terms of biopsy rejection. Coming to the main outcome that we want to discuss in this study, which is the mean decline in the eGFR across the years. There was no statistical significant difference between the group of patients who developed DSAs during their follow-ups and the group of patients who did not develop DSAs. So that tells us that the long-term as a long-term outcome, both groups have the same rate of decline in their eGFR, and that's represented in this graph. So the blue line is the group of DSAs positive, and the orange line was the DSA negative group. So both of them, they had similar rate of decline in their eGFR up to 8 years follow-up so far. So in conclusion, our interim analysis for our study showed that there is no difference in eGFR decline in children who do and do not develop DSAs after kidney transplant. We also found that episodes of biopsy-proven rejection are more frequent in patients with DSA positive, and we also can see from our study that MFI level and timing of detection did not show any effect on the rate of decline of eGFR during follow-up. This is all the data that we have so far, but there is lots of work ongoing. Any questions?
Great, thank you. Questions?
So, thanks for that. Steve, we did the same thing about 10 years ago, or it was Gipna. And that one, there was, I think, similar in terms of decline. It was a 5-year follow-up at that point. So, rate of rejection was much higher on the DSA positive group, and the outcome was worse, but it didn't correlate with the level of specific antibodies. I think my gut feeling is we end up with the same kind of conclusions being
And don't you think there has to be a better marker? Because you showed our data from Seattle and it didn't work except in the people who we did it in for cause. So what do we need to look at next? What do you think is going to be a better predictor?
Yeah, I think it's just looking at the DSAs by itself, and the MFI doesn't look like it's adding a lot, but definitely there is something else that we can look at. I'll leave that to Steve.
So I'll talk a little bit about this tomorrow, because we followed up with the second study, which looks at complement activation. So I think that's the issue is can you predict which patients are going to have rejection? Can you predict those that are going to lose the allgraft? And one of the things that we found was the antibodies which are complement fixing. We'll talk a little bit about the difference between C1q and CPD, so the next step. And what you have is some patients that have donor-specific antibodies with a stable MFI for years that do absolutely nothing. Some patients develop a fleeting donor-specific antibody, some of them have persistent, but actually some patients can have donor-specific antibodies and within a month they fix your complement and then you get the bad rejection, you can't treat and you lose the allgraft. But as Professor Flynn says, it's the prediction of those patients. Some people are using other markers like donor-derived cell-free DNA, but again, that doesn't answer the full question. I think we need a better biomarker to predict.
Yeah, that cell-free DNA test is most of the time indeterminate and not helpful.
Thank you.
Great, thank you.